Youth webinar series that we're holding. Today we will be covering the recommended core pediatric clinical quality measures. I put emphasis on the word recommended as they are not required in 2014 as they were back with the original stage 1 requirements, in which they had a list of core or alternate core reports you had to choose from. While they recommend you selecting these reports for pediatric patients, it is not mandatory. You can pick other clinical quality measures that are more relevant to your scope of practice. Okay, so today we'll be covering the 8 recommended pediatric core measures. Okay? And to start out, I'm going to briefly touch on the report dashboard feature that we have available in ClinicsMD. For those that have attended our previous sessions related to the Stage 2 dashboard reports, you'll notice that they are very similar in nature. Okay? You will find these under the Reports menu. And upon entering, you'll notice that it's laid out very similarly. It just says 2014 CQM dashboard reports. And on screen, you'll notice you have statuses available. For your entire report run, your status are, there's a target not met on at least one measure. Yellow would indicate that the run has not been completed. And then green means the target has been met on all reports. Okay? Now, for clinical quality measures, keep in mind that there is not a minimum threshold percentage you must meet in order to be compliant. The purpose of the quality measures are to improve care in your practice and perhaps identify any disparities in care that may be available. And for these reports, there is a series of rationale in which all these reports were developed. And depending on the measure depends on the improvement notation. In some instances, a lower percentage indicates better quality of care. In other reports, depending on the measure, a higher percentage indicates a better quality of care. Okay? So you want to focus on that. In terms of the status of the report, you'll be on target as long as the denominator is not 0 for a specific report. Since with quality measures, the denominators cannot be 0 in order to use them. You have to report at least a denominator. In the lower half of the screen, you'll notice statuses on a measure-by-measure basis that you have selected. And for each measure, it's going to display your results and your result percentage. And you'll notice in the quality measures, the target just states denominator greater than 0. Then you'll have your status of either green or red. Okay? To the far right, you'll notice that there is a magnifying icon available for you to go and view the detailed patient level for your reports. Okay? For this report, your numerator is 1 and your denominator is 19. The results will then filter out your non-qualified patients, which are listed, defined as those that are in the denominator but not in the numerator. So you can quickly identify the reasons why these patients are not in the numerator. They didn't qualify for a reason. You can then go and investigate it on a patient-by-patient basis. Okay? To set up your provider defaults, very similar to the Stage 2 Auto Measures report, you select the Provider Defaults radio button, have your doctor selected on the left, then go through and select the reports that you want to be listed as your chosen preferred reports for your clinical quality measures. There are 35 available in ClinicsMD, so for essence of a more efficient report run, be best to select the 9 that you're going to focus on covering 3 domains, report domains, for your report period, and just have those reports set up to run. And that will allow you to focus just specifically on those quality measures. You'll notice that in addition to the CMS number for your clinical quality measure, to the far right is a PQRS number. These are reports that share both a clinical quality measure and PQRS. A change for the 2014 clinical quality measures is the ability to use them for both your clinical quality measure reporting and your PQRS measure reporting. We have the file format available in ClinicsMD right here called Generate QRDA that you may use to report for your PQRS reporting. And to do so, you would log into the QualityNet PQRS reporting portal and upload the appropriate files for the year of 2014. How this will work during attestation for meaningful use is that when you first log into a test for the year, you'll be asked if you're reporting your clinical quality measures as part of your meaningful use attestation or reporting them along with your PQRS. If you select the latter, you will continue with your attestation of your core and menu set stage 2 measures, and you'll be able to successfully complete your attestation for 2014. You will then submit your clinical quality measure and PQRS measures together next year by February 28th of 2015. The two systems are now linked on the CMS side to make reporting more efficient, and they'll receive notification that you have reported your clinical quality measures. And at that time, they will then process your attestation for both the clinical quality measures and your stage 2 core and menu set measures, and proceed with payment for your incentive for the 2014 year. But at that point, it would be held until after they received the PQRS reporting through the QualityNet portal. If you do not choose to do this route, you may still report PQRS via the claims-based reporting method that's been available, or through a registry, and report your clinical quality measures separately through the normal attestation process in which you enter the numerator and denominator for each measure. For 2014, the purpose of the clinical quality measures is you must select 9 from at least 3 national quality strategy domains. And they have been leveraged so that they're similar for both quality programs. In ClinicsMD, in addition to be broken out by your adult core and pediatric recommended core measures, you'll notice that their domains are listed prior to the report name. The domains available are care coordination, clinical process and effectiveness reports, efficient use of healthcare resources, patient safety reports, population public health reports. Okay, there's also the non-core reports. And then patient safety reports and patient and family engagement reports. And all the reports are broken out by your domains. Okay. So again, you must pick a total of 9 clinical quality measures from at least 3 of those national quality strategy domains. In both the Stage 2 checklist we provided and also the 2014 Clinical Quality Measure Guide, there are links to the full table of 2014 clinical quality measures along with their assigned domains, which provides the specifications for each measure in greater detail. There's also a link to the United States Health Information Knowledge Base, which provides detailed information about the 2014 clinical quality measure specifications and the related value sets. These value sets are the ICD codes, SNOMED codes, etc., that are used to track the specific criteria in each measure. Okay. A corresponding guide was developed by the National Learning Consortium to assist you with utilizing this tool and implementing your 2014 quality measures. All these links are available in both the Clinical Quality Measures Guide we developed in addition to the Stage 2 checklist. This information can be found under the Help menu in ClinicsMD under the Meaningful Use submenu. You'll notice here that you have either the Stage 2 automated measures and the 2014 clinical quality measures. Here you'll find both the Clinical Quality Measure Guide, which give you an overview for each measure of where the criteria is tracked in ClinicsMD. And then also the clinical quality measure specification sheets for each measure. You can download both of these. Okay. I draw your attention to this information, specifically the specification sheets, as it goes into great detail about how the criteria is being tracked, the rationale behind the clinical quality measure, the improvement notation, for example, a lower score indicates better quality, and the references in which they're basing their clinical rationale to develop this measure. For each data element that's being tracked, for example, patients with a specific diagnosis such as hypertension, there is a corresponding value set in which they've provided that say these are the ICD or SNOMED codes that we define as a hypertensive patient. These value sets are all included in the specification sheets that are available for download in ClinicsMD. Pull one up here for you to look at and see what I mean. For example, the first report we'll be covering today is CMS 75, children who have dental decay or cavities. It goes through the rationale and the clinical recommendation statement, how it defines both the initial patient population denominator and the numerator, and then provides the specific data criteria, those data elements I mentioned, based on a specific value set ID. For in this case, a patient having an active diagnosis of having dental caries is identified with this value set of codes. Okay. In ClinicsMD, we've provided a way to look at the detail of all the data elements included in the specific value sets. So for this report, which is number 75, I will paste that value set ID in this field and click search. We can then see all the data elements that are used to identify a patient having dental cavities by ICD-10, ICD-9, or SNOMED code. So a patient having this in their chart will qualify them for the numerator for this measure as having dental cavities, whether it's by an ICD-9 code mapped to a SNOMED code or an ICD-9 code alone. You'll notice that in some of these situations, some of the value sets, the only data provided at this time is ICD-10 and SNOMED code. This is the purpose of the mapping we've provided to you for ICD-9 to SNOMED CT codes. These SNOMED codes are used to define, and a lot of times a more granular patient-by-patient basis, a disorder, problem, or condition. And it's also used in the CCDA files, the clinical document architecture files that can be sent electronically through direct messaging and used for electronic clinical information reconciliation. So these value sets right here, SNOMED CT, are used in multiple places. Hence the prompting of you to map your ICD-9 codes to those SNOMED codes. When we make the transition to ICD-10 in our next release, which is due out in the fourth quarter, beginning of Q1 next year, we'll be prompting you to do mapping of ICD-9 to ICD-10 codes and updating the report queries to handle ICD-10. Much like the Stage 2 dashboard reports, you have the ability to set up a recurring report schedule based off your provider defaults you've selected. And this can allow you to have the report run in the background on a specified frequency, so you don't have to come in here and manually generate the report each time you want to see the data. Your choices for the report run is time period, is just a quick last 30 days, last 90 days, the entire year, or a specified date range. You then can select the frequency, either daily, or weekly through the Select Days option, or monthly. If you choose Select Days, you'll be prompted to select the days of the week. If you want it just a weekly basis, select only one day. And then, of course, you have the monthly option. When setting the monthly option, you can choose to have it run automatically on the first of the month, last day of the month, or specified day. Once the report run has been completed, you will receive a notification in your system messages that you have a report that's been completed and waiting for you to go view. When you click on that message, you'll be redirected to either the Stage 2 dashboard report or 2014 CQM report. And you'll quickly see on screen your results with the statuses, the day it was run, and your results for each measure. So let's go ahead and jump in. The first measure we'll be covering today is CMS 75. And this is percentage of children defined as age 0 to 20 years of age who have tooth decay during the measurement period. So for that, the birth date and having an encounter during the measurement period would insert the patient into the denominator, and an indication that the patient has dental cavities, such as with ICD code 521.01, would qualify the patient for the numerator. This information is, of course, recorded in either the Diagnosis tab or in the Problem List area of the RxDX List tab. In this case, the rationale is a lower percentage is a better quality. The next measure is CMS 126, which is also PQRS 311, the use of appropriate medications for patients with asthma. The clinical rationale behind this quality measure is that asthma is one of the most prevalent chronic diseases, and it's becoming increasingly more commonplace over the past 24 years. Appropriate medication management could potentially prevent a significant proportion of asthma-related costs, such as hospitalizations, ER visits, missed work days, and school days. Long-term control medications, inhaled long-acting bronchodilators, leukotriene modifiers, cromolyn, theophylline, and immunomodulators are used daily to achieve and maintain control of persistent asthma. In this case, the improvement notation is that a higher percentage indicates better quality. The patients being tracked by this measure are between the ages of 5 to 64 years of age with a diagnosis of persistent asthma and a visit during the measurement period. It's then broken into several subcategories, sub-measurements. And they are patients between the age of 5 to 11, patients between the age of 12 to 18, patients between the ages of 9 to 50, patients between the ages of 51 to 64, and then an overall measure percentage of patients 5 to 64 years of age. This information is tracked by an indication of a persistent asthma diagnosis recorded in either the Diagnosis tab or in the Problem List in the RxDX List tab in an encounter. There are exclusions for the denominator, and those are patients that have COPD, patients that have an active diagnosis of emphysema, patients with an active diagnosis of cystic fibrosis, and patients with a diagnosis of active acute respiratory failure. Those patients with those diagnoses would be excluded from the denominator of this measure, so they wouldn't be included at all in the performance rate. Medications dispensed are the preferred asthma therapy during the measurement period. Again, it's very helpful to use those value sets that are provided in the specification sheets, which again are found under the Help menu in Clinics MD, to look up this type of medication if you have any questions about which medications are considered preferred asthma therapy. So again, you would use this tool, type in the measure number. You can cut and paste the value set ID for the preferred asthma therapy detail and click search. And here are the list of medications that they considered preferred asthma therapy. So the patient being on this medication during the report period would qualify them for the numerator of this measure. Okay? Moving on, the next measure we'll be reviewing is CMS 136, which is also PQRS 366. ADHD follow-up care for children prescribed attention deficit hyperactivity disorder medication. The clinical recommendation behind this clinical quality measure from the American Academy of Pediatrics is that primary care physicians should establish a management program that recognizes ADHD as a chronic condition, and the treating provider, parents, and the child in collaboration with school personnel should specify appropriate target outcomes to guide the management. And the physician should recommend stimulant medication or behavior therapy as appropriate to improve the target outcomes in children with ADHD. The improvement notation for this report is that a higher score, so a higher percentage, indicates better quality. The definitions for this measure, as it is a bit more detailed than others, is you're broken out into two measures. And it's patients between the ages of 6 to 12 years of age who had one follow-up visit with a doctor with prescribing authority during the 30-day initiation phase. The initiation phase is further defined as the 5-month period starting 90 days prior to the start of the measurement period and ending 60 days after the start of the measurement period. Okay? The second measure is the percentage of children 6 to 12 years of age who remained on ADHD medication for at least 210 days, who, in addition to the visit in the initiation phase I just defined, had at least 2 additional follow-up visits with a practitioner within 270 days, so 9 months after the initiation phase ended. So this one is a bit tricky in the wording. Within this is the mention of the index prescription start date. So that's looking at the earliest prescription dispensing date for ADHD medication, where the date is in the intake period, that initiation period, which is the 5 months starting 90 days prior to the start of your report period and ending 60 days after the start of the report period. And an ADHD medication was not dispensed during the 120 days prior to that. So it's really trying to capture those patients that are just newly being dispensed an ADHD medication and having a new diagnosis of ADHD. Patients that are automatically excluded from this measure include those with an active diagnosis of narcolepsy, those patients that have been on ADHD medications 120 days prior to the start of the occurrence of medication being dispensed during the measurement period. And also those patients that have a mental health diagnosis or substance abuse diagnosis before the start of the measurement period. Again, the ADHD diagnosis would be defined by an ICD code that's either recorded in the diagnosis tab of an encounter or within the problem list in the RxDx list tab in an encounter. And of course, medications are then recorded in the prescription tab in the encounter. Moving on, the next measure is CMS 146, which is also PQRS 66, appropriate testing for children with pharyngitis. And the clinical rationale behind this is to reduce unnecessary use of antibiotics. And that group A, streptococcal bacterial infections and other infections that cause pharyngitis, which are most often viral, often produce the same signs and symptoms. So that a lot of times it's a viral infection, not bacterial, and they want to reduce the amount of antibiotics usage. This measure is tracking patients between the ages of 2 to 18 years of age who are diagnosed with pharyngitis and ordered an antibiotic and received a Group A strep test for the episode. The improvement statement is that a higher score indicates better quality. So higher the percentage, the better the quality measure results. Basically making sure that you're ruling out strep prior to putting the patient on an antibiotic. The diagnosis is tracked in either the diagnosis tab in the encounter or within the problem list in the RxDx list in the encounter. And the Group A streptococcus strep test would be recorded in the order entry tab and be a laboratory result. Moving on, the next measure is CMS 154, PQRS 65, appropriate treatment for children with upper respiratory infections. This tracks the percentage of patients aged 3 months to 18 years of age who are diagnosed with a URI and not dispense an antibiotic prescription on or 3 days after the initial diagnosis. Very much like the prior clinical quality measure, is that you're ruling out viral infections and not over-prescribing antibiotics. In this case, the improvement statement is that a higher percentage indicates better quality of care. The diagnosis of upper respiratory infection, URI, would be recorded in the diagnosis tab or the problem list area within the RxDx list tab. And of course, medications are recorded in the prescription tab. The exclusions for this report, the automatic exclusions that are calculated, are patients that have already been on antibiotics 30 days prior to the encounter date, during which that original diagnosis for URI is established. So it excludes those patients from the list. Okay. Moving on, the next measure is CMS 117, PQRS 240, Childhood Immunization Status. This is a carryover clinical quality measure that you may be familiar with already from the original Stage 1 reporting. And it's your percentage of children that reach the 2 years of age before or during the report period who have received 4 DTaP, 3 IPV, 1 MMR, 3 HIB, 3 Hep B, 1 varicella, 4 PCV, 1 Hep A, 2 or 3 rotavirus vaccines depending on the brand you use, and 2 flu vaccines by their 2nd birthday. And of course, in this case, the higher percentage indicates better quality of care. And the clinical rationale behind this is that, of course, infants and toddlers are very vulnerable to infectious diseases because of their weakened, or not weakened, but their immune systems haven't built up the required defenses to fight infection, and childhood vaccines are between 90 and 99% effective in preventing these diseases. Immunizations are all recorded in the Immunization tab in the Encounter. And this report specifically tracks the CVX code, the immunization codes that we discussed during the Setup Guide webinar sessions that are attached to your immunization orders in clinic setup. This information is provided by the CDC. They provide a list of CVX codes, your immunization codes, per immunization order and the corresponding manufacturer codes. And then this report tracks the patients based on those immunization codes attached to the actual order in ClinicSMD. That information is available on the CDC's website, but I can also provide it to all participants of today's webinar, so that you'll have the full list of mapped immunization orders based on brand name mapped to the specific CVX code, aka immunization code, and the appropriate manufacturer code. Okay. The next measure is CMS 153, which is also PQRS 310, Chlamydia Screening for Women. This one tracks patients up to the age of 24 years in age, so it can also be used for patients between the considered non-pediatric, so older than 20 years of age. This is strictly not limited to pediatric practices or those that are seeing kids. It's broken out into 3 sub-measures, and those are the overall patients 16 to 24 years of age who are identified as being sexually active and had at least 1 test for chlamydia during the report period. Those women that are 16 to 20 years of age who are identified as being sexually active and had at least 1 test for chlamydia during the measurement period. And also the percentage of women 21 to 24 years of age who are identified as sexually active and had at least 1 test for chlamydia during the measurement period. You would indicate the patient was sexually active by various ICD codes. Again, those can all be found under the value sets. And that's recorded in the Diagnosis tab or in the problem list area of the RxDX list tab in an Encounter. And of course, your chlamydia lab orders, the orders themselves can be recorded along with your other orders in the Order Entry tab in an Encounter. And then results for that chlamydia test are stored in the Labs tab. This measure doesn't specifically track a specific result for the patient. It just looks for the completed order. The next measure, CMS 155, which is also PQRS 239, Weight Assessment and Counseling for Nutrition and Physical Activity for Children and Adolescents. This is another carryover clinical quality measure from the original quality measures that came out for stage 1. It's broken out by the percentage of patients 3 to 11 who had height, weight, and BMI recorded during the report period. Those patients 3 to 11 who had counseling for nutrition, and then those patients 3 to 11 that had counseling for physical activity during the report period. The second age group tracked are those same criteria, but in the age group 12 to 17 years of age. And then the third set of patients being tracked are those patients 3 to 17 years of age. This information is all recorded in the Vitals tab in an encounter. Once you enter your height and weight for a patient, the BMI is automatically recorded for you. Down in the lower part of your screen. To indicate if you provided physical activity counseling and or nutrition counseling, you may do so by the BMI follow-up button in the Vital Signs tab. You can indicate nutrition counseling that was provided via this list of drop-down responses. Any of these are appropriate. This is the list of appropriate counseling responses based on SNOMED code that are provided in the value set detail for this report. And then you select any physical activity counseling that was provided the same way. You may add additional notes in this field in the free text box. It's not required, nor is the follow-up plan field. This is specific to the adult BMI counseling. So for your pediatric patients in those age groups I just provided to you, you want to either indicate nutrition counseling provided or physical activity provided, or excuse me, physical activity counseling provided. Then click OK. That will insert the patient into the numerator for this measure. Can also be tracked by corresponding diagnosis codes in the Diagnosis tab or in the Problem List of the RxDX List tab. So again, that's broken out into several different strata by age group. And in this case, the improvement statement is that a higher percentage indicates better quality. And the aim of this quality measure is to focus on the emergence of a new chronic disease, which is obesity in childhood and adolescents, and early intervention for those patients. Okay, so that is all the measures we'll be covering today. I built in plenty of padding for a good question and answer session, since these are very detailed reports but quickly covered. So at this time, I'm going to go ahead and open the floor up to your questions. You'll see in the GoToMeeting webinar window, there is a section for questions. You can type in your question here, and it will come over to me, and I will answer them one at a time. So I'm going to give you a good 5 to 10 minutes to ask any questions you may have, and then I'll answer them one at a time, okay? It looks like we don't have any questions from today's session, so we can go ahead and conclude today's webinar. We will be covering other clinical quality measures in groups of 5 or 6 starting next Tuesday, so I'm hopeful that everybody can sign up and participate for one of those. Well, finally got one question. Well, let me go ahead and answer that and we'll wrap up today. For CQM and PQS are 2 separate reporting entities. Yes, you are correct. Clinical quality measures is part of the Meaningful Use Incentive. PQRS is the Physician Quality Reporting System. They are 2 separate incentive programs. With the 2014 electronic file specifications they provided for the clinical quality measures, they are allowing you to use them for both reporting plans that are being run by CMS. But it's not mandated. It's not required. You can still report your clinical quality measures through attestation, just like you've always done, and then report your PQRS via claims level reporting or through a measures group or a PQRS registry. Any other questions? Okay, well, it doesn't seem that we have any more questions for today, so we're going to go ahead and conclude today's webinar covering the recommended pediatric core clinical quality measures for 2014. As always, if you have any questions that come up after today's webinar session, please feel free to forward them my way. I can be reached at mary.brunson@clinicsmd.com. That email address is also provided in the registration emails that you received from GoToWebinar. As always, thank you for participating. I'm so glad you all were able to join me today, and have a great afternoon.